like Dr. Freed said, it's a little bit different, but I thought it was pertinent and kind of something I've talked about or dealt with other medical professionals in my short time here. So that's what I'm doing my Mythbusters on. Sort of table of contents, just going to talk about different cardiac devices, deactivation of those, misconceptions surrounding those deactivations, sort of some in-house stuff, legal, religious, and ethical considerations, and then just recommendations. So pacemakers and ICDs, kind of we already know pacemakers implant into the heart tissue, sends electrical impulses to help the heartbeat in a regular rhythm, and ICDs is a device implanted into the heart that can deliver electrical shocks, sometimes detect the rhythm of the heart and pace the heart's rhythm. Some pictures of pacemaker, single chamber ICD, and biventricular ICD. So deactivation, for ICDs, it's usually involved turning the shock function off via like a laptop ICD programmer or using a medical grade magnet. And pacemakers, it can be using a magnet, but some of the newer pacemakers can withstand that, so you actually do need the technician to deactivate them. So sort of some examples in the current body of literature that I found just with misconceptions about deactivation. The first article outlined 6 different sort of case reports where terminally ill patients and their surrogates requested deactivation of the devices at Mayo, and the cardiology pacemaker consultation service actually declined the deactivation, or the ethics committee had to be called in for consultant in order to actually get it going. The second article kind of showed 17 different manufacturer representative, in-field clinical engineers, and industry technical specialists who, they were surveyed and they kind of discussed experiencing sort of role conflicts and moral distress regarding their activities for in the clinical setting for deactivation, and just kind of what that looked like when interviewing them. The third article surveyed 150 attendees at the annual assembly of the American Academy of Hospice and Palliative Medicine and Palliative Nurses Association, where they were surveyed and had a discussion, and most perceived sort of an ethical difference between deactivation of an ICD versus a pacemaker, where 93% felt more comfortable deactivating an ICD versus only 86% reported feeling comfortable deactivating a pacemaker at end of life. Sort of the fourth article was 14 nurses participating in 3 different focus groups where they were surveyed and sort of discussed how they have a sense of actively participating in a patient's demise when they were deactivating the pacemakers or ICDs, that they felt, really ethically hung up about it afterwards, that they felt that they were the ones who had to end up administering it, more so than physicians, and just kind of the baggage that they held after the fact. And sort of the last article is the bigger of the surveys. They surveyed 787 people, almost half Heart Rhythm Society members, and the other half were device company field representatives, where 56% of them reported that they were comfortable personally deactivating an ICD, compared with only 34% feeling comfortable deactivating a pacemaker, and 22.1% of the respondents reported that they had refused a request for deactivation of a pacemaker, versus only 5.6% had refused deactivation of an ICD, and 11.3% of those respondents actually described pacemaker deactivation in terminally ill patients as euthanasia, versus only 1.3% described ICD deactivation as euthanasia. So just kind of some surveys, some articles, some case reports outlining that this kind of has been a little bit of an issue morally, ethically, and just not everyone kind of knows where things stand. I did create a small in-house survey for any of the medical professionals here at Cottage. It consisted of sort of 10 questions, but some of the more important ones that I pulled out, I surveyed, it ended up being 34 total respondents, 19 nurses, 9 residents, 4 attendings, a pharmacist, and 1 other. So one of the questions I asked was, is it appropriate to disable ICD in a terminally ill patient who has chosen not to be resuscitated? Most said yes, but 3 were unsure and 7 said no. I also asked, is it appropriate to disable a pacemaker in a terminally ill patient who has chosen not to be resuscitated and doesn't want to prolong their life? Most said yes, but 9 were unsure and 3 said no. I asked, do you believe patients must have a terminal illness in order to deactivate their pacemaker or ICD? 22 said yes, 9 were unsure. 2 said yes, 8 were unsure, and 24 said no. And then lastly, I asked, would you describe death in a terminally ill patient following deactivation of ICD or pacemaker as euthanasia? And 2 said yes, and 1 was unsure, and 31 said no. And I know this sort of small survey is obviously very limited by a lot of factors, but just wanted to get a little bit of the perspectives of who we work with and kind of what people's notions are regarding this. So concerns regarding deactivation of pacemakers and ICDs in end-of-life care. There's been, a lot of bioethicists who have gone over the subject over the last 10, 15 years and have reviewed a couple of important things. First is the concept of burden. So kind of the thought that defibrillators can cause physical harm to patients via shocks at end of life, and thus it's more permissible to deactivate them versus a pacemaker. But pacemakers can cause distress and suffering on the part of the patient, the family, and if a patient has the capacity to assess these burdens and benefits for him or herself, then they should be in charge of whether or not it should be deactivated. And in the absence of direct physical burden, there still could be substantial indirect burdens, like continued pacing therapy can cause the patient or family loss of control, dignity, can contribute to fears prolonging the dying process. And there's been some evidence that continuing pacemaker end of life can cause discomfort from the sustained bradycardia. Another topic that comes up is device and timing of death, where it's a thought that deactivation of ICDs can result in death in days or weeks versus a pacemaker, deactivation can result in death more immediately. But in reality, there's no ethical or legal distinction between withdrawing therapy that results in a patient's demise, whether it's days or hours or seconds. And deactivation of the pacemaker would allow an underlying disease process to take its natural course, but it wouldn't introduce an external mechanism of death. So because of this temporal proximity, it can be psychologically difficult for clinicians participating in the withdrawal to separate the action from the outcome. Basically, it kind of explains some of the discomfort for pacemakers versus ICDs. Another topic that comes up is internal versus external, which I thought was really interesting. The thought that the technology has become internal to the body, and so that creates a boundary between killing and allowing to die. And some concluded that pacemakers are, it's been concluded that pacemakers are distinct. Some have concluded that pacemakers are distinct from external life-sustaining treatments like vent support, antibiotics, etc. But even when it's internalized, it's a substitutive therapy, meaning it's distinct from the patient's body and extrinsic to its function. And a lot of bioethicists, outline the fact that the treatment is inside the body, but it doesn't change the ethics surrounding deactivation. So sort of some legal considerations. So first, it's not physician-assisted suicide anymore, it's physician-assisted dying. And it's defined as a physician providing, at the patient's request, a prescription of a lethal dose of medication that the patient can self-administer versus voluntary active euthanasia, which is the physician administering a lethal medication in the patient's request, which that's a typo. It is legal in the U.S. and Canada. Some of the court cases that are really pertinent to this is the Quinlan case. Karen Quinlan, she was a 21-year-old in the 70s who basically was determined to be in a persistent vegetative state after ceasing breathing after an alcoholic incident, and her father wanted to remove her from a medical ventilator, and the clinician at the time didn't want to allow that, and so it was a big court case, and he was eventually allowed to remove it. The other court case being Cruzan, which was a 25-year-old female who lost control of her car while driving, and she was thrown and was also in a persistent vegetative state, and she had a feeding tube placed, and basically the family wanted to remove it but wasn't able to at the time because of the clinicians. But after these two cases, there's basically showed there's no ethical difference between withholding and withdrawing sustainable treatment, and the courts have ruled that there's no legal distinction between that. Some sort of religious considerations. When discussing this topic, there's a pretty well-known case about a 63-year-old man who ended up having end-stage cardiomyopathy, low ejection fraction. He was in incessant ventricular tachycardia. He had an ICD placed. His family wanted it, but a month later he was hospitalized for decompensated heart failure. He ended up getting encephalopathic, and not being able to have decision-making capacity. So his family, it fell to them. They agreed to put him as DNR status, but they were adamantly against deactivating his ICD. And in the days that followed, he suffered, 41 ICD shocks. That was physically uncomfortable to himself. It was uncomfortable to everybody there. And then eventually he passed from asystolic cardiac arrest. They thought the pacing didn't capture because of an underlying metabolic derangement, but basically just kind of how religious considerations, can affect patient care, and how that can kind of look in one scenario. The other one being Catholic or religious-based hospitals. I think a lot of people talk about how abortion is a, kind of touchy subject for religious hospitals, but this is another topic I think that should be considered, because as soon as the Heart Rhythm Society put out their statement regarding removal or deactivation of ICDs and pacemaker, there actually was a senior director of ethics at a Catholic Health Association who, wrote an article kind of saying the opposite, saying that, in contrast to what the Heart Rhythm Society is saying, that patient autonomy is important, but you shouldn't be able to deactivate an ICD or a pacemaker just because the patient wants it deactivated. So just kind of things to keep in mind. Ethical considerations, there's kind of 3 ethical principles that help shape withdrawal of life-saving treatment. So withholding and withdrawing life support are equivalent. Studies show clinicians are, like I said, are psychologically more comfortable with withholding, like a more passive treatment, than withdrawing. But philosophical and legal analyses have emphasized that they shouldn't have any sort of distinction between the two. The distinction between killing and allowing to die, the court affirms that patients and their surrogates have the right to refuse any unwanted medical treatment, even if it's life-sustaining. And actions of the clinicians in this regard are described as allowing the patient to die from the underlying illness. And it kind of goes back to those 2 cases that we talked about. And the last one is the doctrine of double effect, which basically provides an ethical rationale for providing relief of pain and other symptoms with sedatives, even when this may have the foreseen but not intended consequence of hastening death. It's used to draw a moral distinction between giving meds with the intention of killing the patients versus giving them with the intention of making the patient more comfortable, and it's supported in the U.S. by law. The AMA states that when an intervention no longer helps to achieve the patient's goals for care or desired quality of life, it's ethically appropriate for physicians to withdraw it. The American Heart Rhythm Society states that patients don't have to be terminal to have the device removed or deactivated, even though it's more common at end of life. And basically they state carrying out the request to withdraw this life-sustaining treatment is not physician-assisted suicide. They meant death, but it was still called suicide back then, nor euthanasia. And the right to refuse or request the withdrawal of a treatment is a personal right of the patient and doesn't depend on the characteristics of the particular treatment. And they basically, say physician-assisted suicide, death, and euthanasia is the addition of further modalities to affect the patient's care versus deactivation being the removal. So that's kind of the big distinction there. So kind of a question is, what about pacemaker-dependent patients and pacemaker deactivation? Where some medical personnel feel more comfortable deactivating the ICD, like in those other articles I talked about, more have issue with pacemaker-dependent patients. A rationale for this sort of distinction is ICD therapies are intermittent versus pacemaker therapy on a pacemaker-dependent person is continuous, and death might not occur immediately for the ICD deactivation, but it can for more quickly for pacemaker deactivation. But widespread agreement exists basically that withdrawing other continuous life-sustaining treatments like bent is ethically and legally permissible, and we should hold pacemaker deactivation to those same standards. This is kind of an interesting study I found too about withdrawing implantable defibrillator shock therapy in terminally ill patients. Basically, it showed that there was no significant difference between pacemaker-dependent and non-pacemaker-dependent patients when measuring the time to death after discontinuing the shock therapy. And continuing the pacemaker therapy in terminally ill pacemaker-dependent patients didn't significantly extend their life compared with non-pacemaker-dependent patients. And it kind of demonstrated, it was one of the first of the studies in 2006 to demonstrate that continuing pacing therapies in pacemaker-dependent individuals didn't artificially prolong life in those patients whose shock therapy was withdrawn compared to those who were not pacemaker-dependent. And it wasn't randomized, but like I said, it was one of the first of its studies to really support this conclusion in terminally ill patients. So kind of some recommendations for future patient care. The whole talk is basically that physicians, nurses, patients, their surrogates, their family, they might be unaware of the legal or ethical consequences of device deactivation and can regard the process as a form of physician-assisted death or euthanasia. And it can lead to avoiding the discussion of device deactivation altogether, which isn't great because it affects patient care. And also to note, though, a clinician can't be compelled to carry out an ethically or legally permissible procedure if their personal views conflict with, or their values conflict with the action. But in those circumstances, the clinician can't abandon the patient and should involve a colleague who's willing to carry out the procedures, or like ICD deactivation. And a patient with decision-making capacity has the legal right to refuse or request the withdrawal of any medical treatment, obviously terminally ill or not. And deactivation should be about allowing the underlying disease process to run its course and provide comfort to the patient in the process. ICDs and pacemakers are no different than any other life-sustaining treatments, and although they may be superficially different and healthcare personnel can have their reservations, removing or inactivating these devices no different than stopping a ventilator, tube feeds, dialysis, anything like that. And treatment team familiarity with these concepts is helpful because it can lead to more expedited withdrawal of unwanted medical support during end-of-life treatment. And open discussions regarding the device deactivation amongst medical professionals with evidence-based research can help dissolve inaccuracies and promote more patient-centered care. So that's my references, and that's Eddie's.
Okay, before we vote on the question, does anybody have any questions or comments? I guess everybody's crystal clear.
Like
Good job.
Thanks.
Okay, so the question is...
Sorry, that's Eddie's, I think. Oh, no, that's mine still. My bad. It was a new slide to me. I haven't seen that. Keep going.
Don't scare me like
I'm
that.
sorry.
I spent a lot of time putting this together. All right, is it a myth? Withdrawing implantable cardiac electrical devices, specifically pacemakers and implantable cardiac defibrillators, is euthanasia. So we will vote on this. Is that, so is it confirmed? Is it true? Do people think that that's euthanasia? How many think that that's true? I don't see any hands. Is it plausible? Some people think maybe they want to hedge their bets. Maybe it is, maybe it isn't. Anybody? One. And busted. So how many people think this is busted? It's not euthanasia. All right. All right, so come here. Come here.
All right.
So you have to, okay, you have to do this right now. Just
Okay.
tap that. No, tap. Busted.